Thank you for joining us today for an addition to our Virginia Healthcare Emergency Management Program webinar series. My name is Matthew Allen, Assistant Director of Emergency Preparedness with the Virginia Hospital and Healthcare Association. I am joined by my colleague from the Virginia Department of Health, Office of Emergency Preparedness, James Moss, State Hospital Coordinator. The Virginia Healthcare Emergency Management Program, a partnership between the Virginia Department of Health and the Virginia Hospital and Healthcare Association and the 4 regional healthcare coalitions. This program serves to increase the preparedness for healthcare within the Commonwealth of Virginia. A few housekeeping items. All lines will remain muted throughout the duration of today's webinar. If you are connected to audio by phone, please also ensure you are muted. If you have questions for the panelists, please type them in the chat box. We will host a brief Q&A session following the presentation. The slides and recording of today's webinar will be emailed out to all registrants this afternoon. Over the past few years, we have seen an increase in civil unrest throughout the country. These events can impact healthcare operations from either disruption of roads and access to your facility or a potential mass casualty event. The 2024 election cycle has shown a number of protests and could bring additional impacts to healthcare. This webinar will discuss medical facility planning and operations during this year's Republican and Democratic national conventions, other civil unrest events, and the role of the medical intelligence in keeping in front of potential problems. It is our honor to introduce Scott Cormier, Vice President, Emergency Management, Environment of Care, and Safety with Medxcel. Scott, I'll turn it over to you.
Thank you very much, and hello everybody. Glad to be a part of this webinar. And I spent 13 years of my life in Williamsburg, Virginia, and in Falls Church, Virginia. So love the state, stay in contact with a lot of family and friends. So our agenda today is I just want to talk briefly about what Medxcel is and what we do so we can get a perspective of how we manage our incidents. We're going to talk a little bit about why prepare. And I think every year when we see disasters, whether they're hurricanes or civil unrest, there's sort of two paths of action that are taken by healthcare organizations. One is to cross your fingers and hope things go well, and the other is to plan and prepare. We've certainly seen that with the 2 hurricanes in Florida over the past month. Next, I want to talk specifically about what we encountered during our work with the DNC and the RNC earlier this year, and then also some civil unrest that we've experienced at one of our academic medical centers. Finally, I'm going to close out with just a brief talk about medical intelligence and how we use that within our healthcare system. And finally, I have a slide or two just on active shooter. Part of my work is since 2013, I've chaired a committee at Health and Human Services that publishes guidance on healthcare active shooter planning, response, and recovery. And actually, I'm writing the final pages for our 2025 update. So we'll give you some information on where you can download that. And then lastly, we're going to have a Q&A. So we want to make sure that we're answering all of your questions. So a little bit about us. We're part of Ascension Healthcare. We're a large healthcare system that operates in 19 states and the District of Columbia. Listen, we're large, and because we're large, we see a lot of incidents. And we feel it is our obligation to healthcare to share the information and the lessons that we learn, whether they're good or bad, so we can help other healthcare systems prepare as well. In Medxcel, we're a subsidiary of Ascension. We handle a number of things like facilities management, planning, design, construction, facilities compliance, and then my team, safety, emergency management, and environment of care. And when I started this job in 2015, I told them that there was a requirement for me to take the job. And that is, I wanted all safety and emergency management personnel throughout the country to report up directly to my chain of command. And I have experience with other large healthcare systems. And what I have found is that safety and emergency management lived locally. You may have had a national collaboration team trying to standardize things, but it never really worked because you were arguing with the C-suite or a director or somebody about standardizing plan processes and procedures. And we did that. So we have a bunch of different positions. Now, I got to tell you, I'm a very frugal person. So for my 139 hospitals and 2,600 sites of care, I have less than 100 people working in safety and emergency management managing it. Some decisions we made is that we've combined the role of safety and emergency management in our hospitals, in our regions, which is about the size of a state. So Texas is a region for us, for example. I have a regional director of safety and emergency management and environment of care. And then I have a regional emergency management officer. So they're able to operate a state level or regional level emergency operations center to support those local incident commands. Now I have a couple of people on my national team. I have a national director of emergency management. He does a lot of work with the federal government and state governments. I have a program manager, and I have a data analyst. They do a lot of grant work for us. And so the federal government can give you a lot of money for grants. My grant program has been up for about 6.5 years now. I've brought over $110 million into our facilities for security and critical infrastructure protection and resilience, as well as reimbursement from disasters. And then I have an executive assistant that keeps me straight and tells me where I should go and what to do. We are standardized in our program throughout the country. So, for example, I have an emergency operations plan that's standardized throughout the country. 80% of it is word for word, 20% of it is localized. We optimize what we do, which is why I can have less than 100 people servicing all those sites. And we're very, very good at communication. And that's something we established early. And that's where that chain of command helps. When something happens in one of our facilities, I'm notified within a couple of minutes. And then we can either stand by or we can react appropriately. Now, listen, we don't run every emergency from my office. Disasters are local ICS teams support that local disaster. What we do nationally is we support that ICS response. And we take a corporate community approach, which is kind of a play on the whole of community approach that FEMA has to disasters. But all we've done is we've lined all of our business practices to be able to strategically and swiftly support any local disasters. And as a matter of fact, this is how we run our National Emergency Operations Center. So we identified 15 national areas, everything from our legal team to our medical practices to patient safety and clinical services to be able to come together. What that structure does for us is that if a local hospital or some local hospitals are having issues, they're not calling these 15 different business entities and trying to get what they can or trying to get information. And so that's a very coordinated response. The second thing we do is my national team collects a ton of information and intelligence that we're going to talk about, and we share it. So during COVID-19, for example, we had the second patient in the US in January of 2020. We knew the wave was coming, as you knew as well. And so we created national guidance of how we would care for patients, how we would put multiple people on a single ventilator, what our supply chain process was, when people would wear a mask versus an N95. And that way we didn't have 139 hospitals with 139 different committees trying to figure out how to do things. So the other thing that brings to the local incident command is that it takes responsibility out of their basket so they can focus on putting hands on patients. And that's really the role of our national goal, is to make sure we have enough hands on patients and not on yellow pages. Now, why should we prepare? Well, let's talk about the 2024 election cycle. And in case you're not tracking it, there's 26 days, 12 hours, 48 minutes, and 30 seconds left before Election Day. We've had 2 assassination attempts. We've had a last-minute change in the candidate. There's still high prices in the economy. There's high interest rates. Candidates are polling very, very closely. And over the past couple of years, we've seen an increase in civil unrest and violence, part of it due to COVID, part of it due to recognition of disparities in our country, and people voicing their concerns, both physically as well as through social media, as well as through billboards and protests. So I want to talk about the the Republican National Convention first. It was July 14th through 18th in Milwaukee. We have a number of hospitals in Milwaukee. There were about 50,000 people that came to the city, which means hotels are overwhelmed, bars are full, people are getting into accidents, or their illnesses are flaring up, and you have to deal with it, along with the number of dignitaries that were there, both local. So we had a number of people from Wisconsin, as well as some dignitaries from the local Milwaukee area, as well as national people. And if you look at this map, the blue map is this exclusion closed area. And you can see we had a couple of medical practices and a hospital right near this exclusion area. And so what does that mean? Well, first of all, you're going to deal with a lot of partners, everything from Wisconsin Emergency Management and Police to national organizations such as the Secret Service and the FBI. And imagine this, we were coordinating with the USDA and the Department of Transportation as well. When you think, boy, why would this government agency be involved? They're most likely going to be involved. And that's a part of our National Incident Management System that came out in 2005. Our planning started 6 months before the event. And it's really a process to recognize and understand who the players are, as well as recognizing and understanding what everybody's role is and what your role will be. Now, what effects would this have on us? What were we thinking about 6 months before the elections? Well, first of all, public transportation. We have patients as well as staff members that rely on public transportation, and that was going to be disrupted. And so we had to understand what those disruptions were and share the information with our patients and our employees to make sure that they had the information so that they could get to work and get home. Road closures, which affects a whole lot of other people, such as your supply chain, delivery personnel, emergency medical services, any other public safety EMS agencies that you're dealing with. For example, we have a prison near one of our hospitals, and so we have folks from the jail coming and accompanying prisoners when they have to come to our hospital. We have to notify them as well. And then you have to notify your patients because you want them to be able to get to their appointments on time and not be concerned or worried of if they're going to be able to get there. Number two, we could see an increase in patient volume, whether from illness, injury, or a potential mass casualty event. And the third thing you have to think about is communication, congested cellular networks. Now, all of our hospitals across the country are on VoIP. Right? There's very few copper phones or phones that go through a line, up a pole into a communication center. We also use a lot of cellular phones and cellular communication. Some of our security systems rely on cellular to transmit images and data. And so those networks could become congested. Now, one of the things we did when I started the program is that there is a national communication program called FirstNet. If you're not aware of it, look it up online. It came out in the aftermath of 9/11, where we saw just what I spoke about, cellular congestion. People couldn't communicate. And so it's a special band on cellular networks. And right now the government is contracted with AT&T to provide that allows designated emergency management teams and support for emergency management response, like healthcare, to be on this special band. So I have a phone, that's a FirstNet phone, which means when traffic is congested on cellular networks, that I have my own special band that I can use. And we've seen this during storms throughout the country, whether it's hurricanes or snowstorms, where people couldn't get through on their personal phone, but they could on the FirstNet phone. We've also used FirstNet after Hurricane Michael in 2018, when one of our critical access hospitals lost all communication. We were able to put in FirstNet cellular routers to get some of our internet up and running. So look into it. I don't sell it and I don't make money from it. I just want you to be sure that during an emergency that your people can communicate. So what did we do as a healthcare system to plan for the Republican National Convention? Well, we split up into 2 planning lanes. The teams worked together, but each team had a different focus. One was internal and external. So let's talk about the external partners. We planned, we coordinated, we exercised with partners. One of the external partners said, hey, will you set up a bunch of clinics around the city for free and staff it with people and give us medical supplies? And we said, no, we're not going to do that, but we'll help you write a plan so that people can get first aid. And we'll work with public health and we'll work with our EMS agencies to do that. Number 2, we filled our Rolodex. I talk about communication a lot and how in every disaster drill I've been in or any after action report from a real disaster, people always complain about communication. And so what I teach is that we need to have muscle memory communication, which means you need to have a Rolodex. And for those of you younger than 30, a contact list on your computer or cell phone that you know people and they know you and you know their name and you know their face. So you can call somebody in an emergency. I'll give you a great example. I spend a couple of days a month in Washington, D.C. meeting with our federal partners. And a few years ago, we had a hurricane come through Florida. I needed blood to be flown from one of our hospitals in Alabama to one of our hospitals in Florida so they could continue to do surgery post-disaster. We were able to get the federal government to intervene and help us and get that done in a couple hours. If the first time you're talking to your counterpart, who you're going to ask for assistance, is during the disaster, you need to know them. And what I tell my teams is not only know who they are, know everything about them. Who's their family? What are the significant birthdays? Maintain that contact. So my team spent a lot of time with their healthcare coalitions at state emergency management and health committees, and me at the federal level, making sure we know those people. Know how to ask for information. Is there a process? Is there a form? Is there a website that you have to complete? Know that in advance and train your people to do it. Make sure if they're establishing an emergency operations center, whether at the state or local level, that you have a chair in it and designate one of your people to be there. You can hear a lot of good information. You can help expedite any requests that you have. And then make sure that your healthcare security or police personnel understand how to get in contact with local police, including what frequencies they're on, so you can talk to them. Internally, we made decisions about incident command. Now, we run a lot of virtual command. We have found that when you take all of your healthcare leaders and stick them in a boardroom or a command center in a hospital, you've pulled them away from their ability to do their work. I'll give you an example. My supply chain people typically live in the basement with all their contact lists and with contact to their people and all their resources. When I pull them into the boardroom or the incident command room and I take them away from there, I take away their ability to efficiently do their job. And so we make sure people can work and do the job. We have huddles and communications, but we want to make sure that they can do it from wherever they may be. For the hurricanes in Florida right now, we're running a lot of virtual command, which is people are available by phone, web, internet. If we think there's going to be a communication disruption, we'll put our command team in a specific location, but not everybody, only the people that we need. Our internal teams notified our staff and our patients about road closures and transportation issues. We mentioned that earlier. We had extra supplies ordered. And we did that just because we don't want a delivery happening in the middle of convention week and too much traffic for the supplies to get through. Also, in case we saw an increase in patient, we wanted those extra supplies, so we worked with our suppliers to do that. We increased the patrols on our grounds in case people wanted to park their cars there because of our proximity, in case they wanted to protest there. As a matter of fact, at our hospital in Waco, Texas, when they had the eclipse earlier this year, people tried to get into our hospital to get to the roof to observe the eclipse. If you're near a place where there's going to be a large event, people may want to try to get to your roof. So make sure you secure that. Increase rounding on all your external doors. I have problems, I know you have problems with people propping open doors so they can sneak outside and smoke a cigarette or get some fresh air, right? And you have to do increased rounding on that. Enforce ID badge compliance. I actually have my team using double-sided badges so you can't turn it backwards. But this is a good time to remind all your staff that they are the most important security asset. And so wearing a badge, questioning questionable people or packages, knowing who to call in case there is a concern, all those things, it's always good to remind them before any of these events starts. And we do that a lot in our huddles, as well as how do you stay safe. And then we are constantly monitoring with special focus on census and bed availability. And the week of the convention, we were pretty darn full. At the end of the convention, it turned out there was only one unusual incident. There was a shooting a few blocks from one of our sites. It wasn't related to the convention activities. We didn't see any major injuries or illnesses. So then the question always comes, did we waste our time in planning? And the answer is no. Listen, I think in some cases you can really over-prepare. And so we try to level set with our preparednesses, understanding what we expect, and then the extreme to the left and to the right. And we felt that the time and energy was well worth it. As a matter of fact, we used that team to help our teams in Chicago plan with the Democratic National Convention. Again, we had exclusion zones, and Chicago was unique because it's a much more compact city, but the convention was being held in two different locations that were 5 miles apart. So it affected a larger number of our facilities. Again, about 50,000 attendees, all those dignitaries. We had a site as close as a little more than half a mile to 16 miles from the exclusion zones. So dealing with these two events, and again, we got a request. Will you put up first aid stations? Will you do this? Will you give us free stuff? That's where that muscle memory communication comes in place, and we help then plan for medical emergencies. So again, internal, external. With the external, we actually had two teams looking at each of the sites. Again, we come back together at the end of the day. There were over 200 protest groups registered for the DNC. The local police, and the local police was supplemented by out-of-state police departments. So they had people from Pittsburgh, Pennsylvania, their police department working there who aren't familiar with the process, as well as state police, sheriff's office. And they had a mass arrest program. So they were expecting a lot of arrests. They had a mass arrest program where they could arrest a bunch of people, process them, and then set them free so they could protest again. If they have a mass arrest program, if you have that, are they going to need medical clearance? And if so, how do you clear them? Do you clear them at the site, or do you clear them at your hospital or one of your outpatient centers? And so that's a big part of the planning. As a matter of fact, new arrivals to our country were planning to enter Chicago as part of the protests and recognition. And the University of Illinois has a hospital in downtown Chicago, and they were planning a strike during the convention. So a lot busier than what we saw in Milwaukee. So internally, we made kind of the same decisions. So we have in-person command or virtual command. At a couple of our hospitals, we did do in-person command just because of the busyness and the proximity. Again, public transportation and road closures, and the bed availability and census monitoring. So those things that we learned in the Republican National Convention, we thought were helpful, and we kept it the same for the Democratic National Convention. At the end of the convention, what did we find? We found a few bomb threats. We had a kind of a weird incident occur. We had, in the middle of the week, we had two people identify themselves as being from the U.S. Department of Homeland Security, come into one of our emergency departments and say that they wanted to restock their IV supplies. And so they wanted some bags of ringers and saline and some IV administration kits. And so we said, no, we don't do that. We asked for their identification. We used our muscle memory communication to call our friends at the Department of Homeland Security. And it turns out they actually were from the Department of Homeland Security, but they were violating protocol on doing that. And so we reported them and they ended up getting disciplined for that. So I like to say part of my job is to tell people no. And that was a time when we told people no. So we don't make assumptions. We always validate people to make sure they have ID. And you have to make sure every one of your team members knows that, because it could be a housekeeping or facilities or a clinical person or a volunteer that is first approached with that question. And they have to understand not necessarily the answer, but know that it's something that they need to escalate to somebody. Once again, we thought it was well worth what the planning that we did, and we don't feel we over prepared or prepared that we did it about right size it. Now, something else happened earlier this year too. There's been a lot of protests about the Hamas and Israeli war. And one of our hospitals is at the University of Texas. And there were 2 weeks worth of on-campus protests. These protests happen to be pro-Palestinian protests. And there were, once again, mass arrest program. I think they were arresting 200 plus people per day. Now, this is our hospital. It's right in the middle of campus. It's a level 1 trauma center. It's also stroke STEMI neuro center, 391 beds. And what we don't want to do is have our services impeded that critical patients can't get to our facility. So how did we plan for this? And we didn't have the 6 months to plan for this. We had about 24 hours to plan for this. So we looked at what things could affect us. First of all, the University of Texas has campus police, so they're sworn officers that can enforce law on campus and just outside the boundaries in Austin, Texas. We also have armed hospital security that aren't sworn officers. We had the Austin police and state police there, and so we needed to understand, just like the DNC and RNC, how are these people going to communicate and connect? We needed to protect our campus from three things: people, cars, and packages. And so, first of all, when it came to the staff, we have to say, are they involved? Are they part of the protest, or do they have a strong enough opinion that they'll do something with the protesters? Next, how is public transportation and road closures being affected? Now, again, we didn't have 6 months to plan. So timely communication to your staff about road closures or parking closures or interruptions in public transportation is critical to make sure that they can get to and from work. Do your staff feel threatened? For example, some of our staff, based upon their religious preferences, may have felt threatened by having these protesters there. And so you may want to consider things like having escorts for them to and from their vehicles. Will the protests make it to our hospital grounds? It didn't, but part of the reason why it didn't is because we secured our perimeter. That means bringing in extra security. Now, I know sometimes when I started this role, hospitals used to call our facilities maintenance department. Hey, we need you to do some security stuff, or we have a combative patient, or we need you to block off the parking lot. And I stopped that right away because facilities maintenance people aren't trained to do that. So if facilities has that role, make sure that they're trained to do it and make sure it's not just an orientation, right? Because they may have to de-escalate, they may have to put hands on people, and you don't just want to call them because you think they're these big burly people with pipe wrenches that can intimidate folks. It's not like that at all. There's an increased potential for hoaxes. We tend to see with these campus protests a lot of bomb threats, people that are wearing a cell phone on their side that people think are a gun. And so there's sort of this heightened concern that can lead to hoaxes. And once again, access to the top of your structures and also access to your parking structures as well as the top of the parking structures. Some things you may want to consider is restricting traffic flow, so closing off some of the entrances to your facility or some of the parking areas of your facility, and so that you can slow traffic down and give people barriers that they have to deal with instead of trying to sneak in. Again, extra security and police. Outside foot patrols, checking all those exterior doors to make sure they're not propped open. Extra vehicle patrols. So we brought in some extra private security with cars to do rounding and then making sure they're incorporated into that security law enforcement plan. And then don't forget about, you may get patients exposed to anti-riot agents. And we did. We saw a number of them. Now, the good thing about anti-riot agents is that they're pretty much not going to cause long-term complications. As a matter of fact, if you know anybody that served in the Marine Corps, when I was in the Marine Corps, every year I had to be exposed to tear gas and other noxious agents. And they made us sing while we did it, which I can't sing without me choking on tear gas, so it didn't help me at all. But I knew that when I was done and I left the area, I would hold my arms out and walk into the wind, and that pretty much took care of it for me. You may have to do some irrigation. So make sure you have extra irrigation supplies or bring some extra to the ER. And then just make sure that your staff isn't getting exposed to this as well. It can get on your clothing, so you want to be careful of that. It's not going to close your ER because you have some people in there that have anti-riot agents on them. Also remember, protests occur during the day and night, just like disasters happen at night and on weekends. So make sure that you're staffed enough, not only on the security and police side, but on the clinical side to take care of any additional patients. And you can see this nighttime protest just outside of our hospital. All right, so 3 lessons. We had the protests, we had the RNC, we had the DNC. I want to talk just a little bit about medical intelligence. What is medical intelligence? Well, it's a tool for you to develop what we like to call situational awareness and domain awareness. Domain is the dome that's around you in your organization and what's happening within that dome and outside of the dome. And then situational awareness are what are things that can affect it. What I like to say is my team provides information and intelligence, and we'll define it in a second, for our leaders to make better, effective, and efficient decisions. And we do data and predictive analytics. So again, I have a small team. And so they can multitask, but this has been very, very effective for us. Now, medical intelligence is part of the National Incident Management System. Mine sits as part of my National Command Center. And so I have 2 people that do that as part of their other duties. But it's very important for you to really consider this. And I'll give you an example I use all the time. Weather is probably one of the biggest vulnerabilities that we have as healthcare organizations. If the only information and intelligence you put into it is buying a big screen TV to watch local news or the Weather Channel, then you're not addressing the issue. So let's talk about information versus intelligence. And it cost me about 100 push-ups at Fort Huachuca, Arizona, to learn this, but it was a valuable lesson to me. Intelligence is information that has been analyzed. And so what we want to provide our leaders is this intelligence or this analyzed information so they can make a decision. Information can be limited. My team sends me snippets. Probably 4 times a day, I get an alert of an active shooter somewhere near our hospital. It's never an active shooter, right? So I can't react to that. But what I have to do is understand, well, what are our local people thinking if they're hearing this? What is actually going on? Do I have to secure my campus? And there's a ton of information out there. I mean, just remember when we all went through COVID-19 in 2020, and the information people were getting from Facebook and other social media, and you had the World Health Organization putting out some guidance that differed from what the CDC was putting out, and you're trying to turn and say, well, what am I supposed to do? Our teams collect all that information, we turn it into intelligence, and then we disseminate that intelligence. Now, some successes we've had with it. A few years ago, as you remember, there was an iodinated contrast shortage that affected about 60% of the iodinated contrast shortage market. Our teams were monitoring factories in Shanghai, where this one factory was that produced all this iodinated contrast shortage. And we saw that there was an increase in COVID cases and that they were considering closing the plant. We notified our supply chain people, and being good stewards, we also notified the federal government and our healthcare partners that, hey, this is going on. Our supply chain partners then did a couple different things. They started to put together guidance on how we could conserve iodinated contrast, and we started to look to see if we could buy additional supplies of iodinated contrast. 2 weeks before anybody else reacted to it or it made the national news, we were ahead of the curve. Supply chain interruptions. We're currently dealing with helium plastics, blood culture vials. We've been a week to 10 days ahead of all those things so we can get a heads up. Monkeypox. When monkeypox re-entered the country about 2 years ago, our teams were ahead of it 10 days before the CDC made an announcement. We actually saw monkeypox in our hospitals in Chicago, and so our teams were well prepared because in that 10 days, we created guidance and screening for our clinical teams. And then recently, Hurricane Helene, we identified that the Baxter plant could have been damaged 2 days before it hit national news. We worked with the federal government on it. Unfortunately, they didn't listen to us, and now all those supplies are lost. But again, it allowed our supply chain to look and see that we don't use a lot of Baxter supplies, but to put in conservation strategies in case there was a shortage because other people were pulling from our suppliers, right? So it works really well for us. We put out what I call medical intelligence or MEDINT briefings, and this is a couple of the MEDINT briefings we put out. And it is, what's the bottom line? How is this affecting us? And how are we reacting? Really simple. I keep these to one page because that's all anybody can read. And we share it appropriately. And we don't just share it with an email. We share it with a conversation about the high points and how it's been useful. Also, speaking of hurricanes, you know, I want to show you some pictures we get. And this was for Hurricane Helene. Now, we have a number of hospitals, both on the West Coast and the East Coast of Florida. And I paid for a private meteorological service to give me pinpoint accurate GPS coordinated weather forecasts. So Hurricane Helene, category 3 hurricane, right? But what does it mean to the dots here? All these dots you see are my locations. What does it mean to that? Well, I know at this hospital, I'm going to see some max gusts, right, of category 1 strength, but mostly my max winds are going to be in a tropical storm force winds or below. This is huge information that says, should I evacuate or should I stay? And if I stay, what do I have to deal with? Do I have to deal with flooding? Do I have to deal with wind damage? And so we have a process of clearing drains, walking ground, securing construction projects, all that. We do this every year, right? But this is what medical intelligence is. As a matter of fact, in 2018 with Hurricane Michael, that was a category 5 hurricane, but we saw that we were going to be able to stay open. And while hospitals around us closed, because I don't think they had the good intelligence that we had. We stayed open and we served the community. And so that's what I mean by medical intelligence. Let's face it, at the end of the day, this medical intelligence postures you to be able to have the right response, but it's also a huge impact on revenue as well. Because when you're able to stay open safely, you're not only serving the community, you're continuing to generate revenue, and business interruption insurance never covers all of your losses. As a matter of fact, when those other two hospitals closed, we gained some new patients because they were grateful that we were able to stay open. All right, we're going to wrap this up with active shooter. Just some brief stuff. I'm not going to teach you about active shooter, right? There have been 22 active shooter incidents inside healthcare facilities, whether it's a clinic, hospital, or long-term care, in 24 years. It is not something that occurs every day for us. As a matter of fact, we think that an active shooter response is so specific that we do not bundle active shooter response with all kinds of other violence. We don't have a violence policy. I have an active shooter policy. And then I have a firearms policy if people come in, because we see a lot of handgun incidents in hospitals and healthcare clinics every year. We see murders, we see murder-suicides, we see people euthanizing a loved one, but it's not an active shooter event where somebody's walking down a hallway squeezing a trigger. And so that's why we differentiate it, because our response is different. Here is the link that you can get. This is the guidance that we created in 2017. COVID slowed us down a bit. As I said, the 2025 guidance is being wrapped up. And it talks about a lot of good things. It talks about IEDs. It talks about triage. We interviewed a lot of people that experience active shooter events, and we talked about the aftermath. And there's an expectation that at the 1-year anniversary, you do something. It takes you 12 months to plan for it. We talk about how do you interact with law enforcement. There's a whole law enforcement section that tells law enforcement how to operate inside of a hospital, like don't bring weapons into the MRI suite. So please look at it, and again, know that we're updating it. Finally, thank you for what you do each and every day for our patients, our communities, and our associates. And with that, I'll turn it back over to see if we have any questions.
Thank you, Scott. And we'll now take a few moments for questions. Please type your questions in the chat box. See Kim's hand raised. Kim, I'll give you a few minutes to type your question in the chat box. I can't come off mute. Or attendees can't come off mute. Sorry. You can use the questions widget or the chat widget. I'm monitoring both. Oh, great. No question. Applause for a great presentation. Agreed. Thank you, Scott. Scott, have one question here so far. So in today's healthcare environment with limited resources, how do you justify the full-time equivalents and spend to realign your teams and reporting structure?
Yeah, great question. As I told you, I'm frugal. If you exclude my 2,600 outpatient sites, and you look at my FTEs per hospital, I'm running at 0.6% FTE. That includes my position and my leadership positions. So many of my safety/emergency management people cover a couple of hospitals, and it worked for us. And I think it works for us because we've created a support system with my other safety officers there as well. So, and my team's always asking for more staff. Now, for my outpatient sites, I have 2 safety officers dedicated to them. We teach them how to fish. So we create tools and resources for them to be able to manage emergency management, safety, and security, and all of those things. and then they're an escalation resource for them as part of their response processes. So we're pretty tight. As a matter of fact, when I look at other health systems, some of them have a whole separate safety and emergency management staff with FTEs, and that's more than my 0.6.
Got so next question is focused on grant researching and writing, and the question is, what of your full-time equivalents are dedicated to that mission?
Yeah, I have 2 FTEs dedicated to that. And here's a cool thing about a lot of these federal grants. 5% of that grant can be attributed to your grant writers. So I pay my grant writers well, but last year they brought in $560,000 to my team for the time they spent on the grants. And while I pay them well, I didn't pay them $560,000. So they actually more than paid for the time that they're doing it. And they're also very good. So remember that muscle memory communication? They meet with FEMA, they meet with state emergency management. Those are the 2 people that you have to deal with grants with. When I started this in the aftermath of a hurricane in 2017, it took me like 2 years to get the money. I'm getting money in 6 months. So we've developed a very, very good process. And we've actually consulted with other healthcare organizations about how they can get a team up and running. Last thing I'll tell you is Ascension has its own clinical grant team. We're separate from it, but we communicate with them. My team brings in more money than a clinical grant team.
Yeah, I see no additional questions at this time. So reminder that the slides and the webinar recording will be emailed out to all registrants this afternoon. We're grateful for Scott sharing this valuable information with us, and we thank you all for joining us today. We hope everyone has a wonderful day, and this concludes our webinar.